We're not in it to make a buck here. We're not in it to make it basically build a piece of equipment that solves a problem in an expensive.
But I think you should. And I think you should make a lot of money. And the reason why is that when I look at society and I see things that are really not that important and they're making a lot of money versus stuff like this that are going to save people's lives, like I'm actually very happy if you make more than just a buck on this. So I'm very pro like medtech founders, clinicians making a lot of money to come up with things that save people's life. But the thing that's interesting about devices that's different from devices, we come up with interventions to save people's lives. So I'm very pro. I hope you make a lot of money.
What we want to do is we want to make devices that really matter and really make a big impact at the right point of view. And where we're going to make money is when look at this and say that just makes so much sense that we just got to all do it.
Welcome to the #1 show and the source of truth for all things medtech. Here, we reveal the secrets and stories behind the investments, science, and commercialization of the medtech industry. Every week, we'll take you on a wild ride with the biggest names in the game, from entrepreneurs and investors who are shaking up the market to healthcare providers who are revolutionizing the way we think and practice medicine. So hold on tight and get ready for a journey like no other. This is the State of MedTech. Hey everybody, welcome back to the show, and I am fresh and back from my trip to Paris visiting Moon Surgical, an exciting new surgical robotics company that Khateeb & Co is going to be helping, and I'll be telling you a little bit more about that soon. Now, today's episode is an interesting topic where, during the pandemic, we learned a lot about the risk of ventilator-associated pneumonia, mainly because people were put on mechanical ventilation devices. During the time and during 2020, I became friends with Dr. Benjamin Wang, who's the founder of NeVap. NeVap is a company whose mission is focused around airway management devices that improve outcomes, reduce complications, and lower costs. Now, airway management doesn't end once an artificial airway is placed, as breathing tubes can act as a path for infectious agents to enter the lower airways. This is why the leading risk factor for pneumonia, postoperative ventilator-associated and aspiration pneumonia, is the presence of a breathing tube. So when you think about subglottic drainage of the human airway, it is actually recommended by the CDC, HRQ, ATS, SHE, all the governing bodies. Numerous meta-analysis and randomized control trials show it reduces time on mechanical ventilation, pneumonia incidence, and antibiotic needs, along with mortality. So Nevapp developed a device that is the only subglottic breathing tube designed with a tissue spacer and multiple ports to prevent tissue blockage. This design results in significant better airway drainage and the ability to apply this infection prevention strategy in the ICU, OR, and ED. And you can learn more about them at Nevapp. And let me tell you a little bit about Dr. Wang. Dr. Wang is a physician entrepreneur focused on creating impact and value on the lives of the most vulnerable patient population, specifically critical care. He completed his undergraduate degree at UC Davis and then went and did his medical degree at the University of Miami Miller School of Medicine. And his current work is with NeVap, which stands for Never Ventilator-Associated Pneumonia, which is focused on helping to save the lives of the sickest, most vulnerable critical care patients on invasive mechanical ventilation. He founded this company after he saw a vulnerable patient suffer because the breathing tube that they were using was causing deadly antibiotic-resistant infections. And today, his mission is to focus specifically on those critical care patients. Now, on his LinkedIn, I have to put his most noteworthy failures. So this is on his bio. His most noteworthy failures include getting a B in 6th grade math because his handwriting was unacceptable, getting a C in Korean language class while studying abroad, and interviewing at UCSF and UCLA School of Medicine and getting a rejection letter. So really epic failures. So, and I want to remind our clinical audience, if you're looking to get a free CME credit, you can unlock one thanks to our partners over at CMFI. Just click the link in the show notes. click the link in the show notes below and unlock that credit. And lastly, if you're a startup founder and you're looking to improve how you find early adopters are the most important things when it comes to finding the right adopters for your technology early on. And so that's why I've partnered with Alpha Sophia. Alpha Sophia is a database and commercial intelligence company where you can look up physicians to see how many of them are doing the most procedures, what their prescribing habits are, even their social media. And to get a free search, actually not one or two, but 3 free searches on their platform, you can go to alphasophia.com/Omar and learn more. Now, let's get on to our episode with Dr. Ben Wang. Welcome back to the show, everybody. So I'm joined by a friend of mine who we befriended each other during insanity known as the COVID-19 pandemic in 2020, and that's Dr. Benjamin Wang, who's the founder of NeVap, which is an interesting company in that it focuses on making mechanical ventilation a lot safer. We got very familiar with mechanical ventilation early on in COVID, realized that was probably not a good idea, but people made the best decision that they could at the time. But with that being said, Benjamin reached out to me specifically just in terms of the problem that mechanical ventilation brings up, and then more so is that while we're out of the COVID-19 pandemic, COVID is still around. People still get sick and go to the hospital, and so this is still a large issue. So, Dr. Wang, maybe we can sort of take it from there and frame it up. Like, first of all, give us a little bit of background on your clinical education.
So I'm an American trained U.S. Medical doctor. I'm an MD. I trained at the University of Miami in anesthesia, critical care, and I left practice because I saw a need that wasn't being filled by current medical device companies out there, which was to make mechanical ventilation safer and better for patients. I founded this company NeVap, and the original idea was that NeVap would stand for Never Ventilator-Associated Pneumonia, and from what most people don't know is when a person has a breathing tube placed in their mouth and it goes into their lungs, that breathing tube is basically the most common, least appreciated medical implant in the history of modern medicine. We put more of these tubes into people's bodies than literally any other implant and any cardiac, all the cardiac implants put together.
Yeah, that's actually a really good point. I had because anytime somebody goes into surgery, anything, that's a great point. I never thought about it like that.
We really on a yearly basis we put literally hundreds of millions of these devices, and quite frankly, they haven't been improved upon since basically the 1950s. So we're still doing that, which we were 50, 60 years ago, the same way that we are today. And during COVID, this is so interesting. We fell back on this piece of equipment in enormous numbers, and when it backfired that these tubes were making people sicker, it never occurred to anybody to come back and say, hey, we got to look at the science and see if we can upgrade these tubes and make sure that they don't cause complications. Everybody threw up their hands and said, well, I guess intubating COVID patients is not a good idea. Well, if you have somebody who's very sick and headed in that direction where their oxygenation is just not meeting up and getting up to snuff, you can try all the other modalities of ventilating them. But at the end of the day, the gold standard, the thing that's going to keep them alive in most cases, is still that same plastic breathing tube that goes from their mouth into their lower airways.
Yeah, it makes a lot of sense. Well, if this is the case, right, it's such a commonly used thing, why hasn't it been improved upon?
It's reliable. The vast majority of people don't see the complications. Nobody complains. They're all unconscious. So it's one of those things where it's almost out of sight, out of mind, and as a consequence, not a problem until it truly is a problem. And there's a couple of these interesting use cases in modern medicine where people have accepted the consequences without thinking that there might be opportunities to improve upon, the gold standard.
Oh,
If
go
you
ahead.
think about it carefully, a breathing tube is basically a plastic tube that goes in a person's mouth and goes into their lungs. And if you leave something in a person's mouth long enough, like a straw or a lollipop or a piece of candy, what happens is saliva and bacteria will kind of grow on the surface of it, and they'll use the surface of that straw or that lollipop as a place to kind of go down in other places. So if you've ever brushed your teeth a little too long, you've noticed that if you're not careful, you'll have a little bit of toothpaste on your hand if you're not careful. But imagine the reverse of that. You have something that's in there, you're unconscious, you can't do anything about it, and instead of coming out of your mouth, it goes down into your lungs. That
Right.
happens literally in millions and millions of patients. And while if you have it only if it only happens a little bit and for a little period of time, it's not a big issue.
What would be a little period of time?
Half an hour,
So
so
I would say the lion's share of most surgeries are not a little bit of time. Even like really fast ones are at least 45 minutes, right?
very
And so
true.
essentially the issue is that you have something that's in the lung, which is almost a perfect bridge for saliva, which is not sterile, to kind of find its way down there. Not to mention
Yeah.
other things, right? And then this is kind of the issue with it's not catheter associated pneumonia, it is ventilator associated pneumonia.
Yeah.
Got it.
But what it really should be called, it should be called breathing tube related pneumonia, because it's the people who have breathing tubes that get these types of pneumonias.
Got
And
it.
what's really interesting about this is during COVID, approximately half of the people put on ventilators with the tube in caught this pneumonia. And when they caught this pneumonia, there's new studies that have come out actually this year about it. The mortality rate in these COVID patients jumped up 600%.
Can you now I do want to get a little clinical on you. Can you go through the physiology as to why that is? Because I think that makes sense to me, but I always try and push my audience's thinking, especially the reps who are listening.
Mm-hmm.
So I always recommend that, like, if you're really serious as a rep, get guidance physiology. But why is it that if you get pneumonia, your mortality jumps up so much? Like, what if you can walk us through a little bit of the physiology behind that?
So if you think about a virus is inflammatory to begin with. And when it gets into your lungs, it starts to cause a bunch of inflammation. Inflammation in the lungs usually leads to fluid buildup. And when you have too much fluid in there, then the air can't mix with the blood and you can't oxygenate well. Well, if you get a second pneumonia on top of that, which is what happened in these COVID patients, the bacteria come in here and they will not only create an inflammatory response, but they'll try to grow, and they excrete all kinds of additional substances to help them grow and create an environment for themselves. So they create additional fluid buildup, and that makes um, the oxygenation of the patient significantly worse. If you have people don't know this and don't think about this oftentimes, they think, okay, the lungs has a capacity of several liters, like 4 to 6 liters. What most people don't understand, it only takes about 150 cc's worth of fluid, or 150 milliliters. Think a fourth of a can of Coke, to drown somebody. So when a virus or a bacteria pneumonia happens and it's creating inflammation down in the lower parts where um, the gas exchange is happening, all it has to do is disrupt enough that you get fluid buildup, and
And you
then a
said
lot of,
a fourth of a can of Coke. So it's
yes.
actually not, this is analogous to, it's kind of like what people don't realize is, like, for fog, I think for like something
Mm-hmm.
like an acre of fog, it
Yes.
literally just takes like a cup of water. That's it. That's the amount of water that's for an acre of fog. So I guess on the same side, like, I had no idea that just like a fourth of a
A
Coke
can of
can
Coke.
is enough to
Right.
drown somebody.
Yeah. It's in the wrong place at the wrong time. But what's really interesting is after this sequence of physiological events that happens to the patient, we come in here and we ventilate the patient's lungs in the same way that we would ventilate a healthy lung. Remember, if all the fluid is at the bottom and now all the inflammation is happening in the lower lobes, what happens is this leads to something called acute respiratory distress syndrome, or ARDS.
Because yeah, that's it. Okay. So this is like an MCAT question. So you
Yes,
essentially, so you have something that's would it be hypertonic because of all the inflammation and inflammatory markers down there?
yes,
And then you add the fluid there, so it's
yes.
no longer hypertonic. It's maybe more hypotonic,
Hmm.
and then as a result, your lungs are trying to compensate and pull fluid in a different direction, and it just makes it worse.
Yes,
Damn,
yes.
you know what
Now, wait. There's more to this
there's
story.
more,
There's more, and
but
it's
there's
so
more.
fascinating. There's so much more to this. So now, if you look at the death certificates of these patients who died from COVID, what you see a lot of is ARDS. So
And
everybody attributed the death and the problems of COVID to ARDS. But now the more interesting thing about this is after that fluid started to build up and after the patient lost their ability to properly shunt blood to the lungs, all the blood ends up shunting itself to the bottom lobes and all the air goes to the upper lobes. And that's when we start proning people to try and rebalance the amount of um,
ah,
now, what we also did was we ventilated all of these patients the same way we would ventilate a healthy patient with one tube. So we treated the very blood engorged lungs with the basically empty lungs without any blood. And what that did, it created a lot of ventilator induced injury or pressure
yeah,
injury.
because like being on a ventilator for like funny enough, I mean, I knew this, but like it's becoming such a popular thing. Elon Musk talked about this on Joe Rogan's podcast just recently, where he's like, yeah, he's like, this is why like the ventilators were a bad idea because like being on a ventilator for a few hours is okay, but when we run on for a week, it fries your lungs.
Right, right. But you see, we've had this paradigm with ARDS for the last 70 years. That's basically as long as we've had any modern ventilator. We've known about ARDS, and we've just basically thrown up our hands and said, when you have somebody who has ARDS and you push more air in there and their oxygenation goes down, you're in trouble. There's not much we can do. All the pharmaceutical agents that should otherwise be utilized in this case have never panned out. And here at Nevapp, we look at this and we say, this is crazy. We know the basic science behind this. We need to design a system that can isolate and provide um, lung lobe specific mechanical ventilation. Because if you can isolate and you can keep these patients successfully on a ventilator without frying their lungs, and I don't like that term necessarily because it's not as accurate. It's really more overinflating and underinflating different parts. But
Mm.
if you can prevent that, you can prevent the injury, the mortality, the morbidity, and you can keep them off ECMO, which is extracorporeal membrane oxygenation, the most expensive,
Yeah, it's really
dangerous part of
expensive.
modern
It's
medicine.
great technology, by the way, but it is
It is.
really expensive.
It's mind blowing, but I've never seen it
You
implemented
walk
without
people
15
through
people.
the majority of people on this show, with the
Mhm.
exception of some of the critical care folks, have no idea what ECMO is. Can you please explain it to them because it is insane how ECMO works. Just if you can explain it
Okay.
just briefly.
In the simplest,
Quick
most
sidebar.
layman way of explaining it, it is basically once your heart or your lungs cannot properly put oxygen into your blood, the next step is they take the blood out of your body from a major artery or vein. They run it through a machine that mixes the blood with oxygen. And I'm oversimplifying that on purpose because that's also very interesting science. But they mix the oxygen with your blood and then they pump the blood back in. So they have a machine that's basically doing what your heart and your lungs are supposed to do.
It's wild, but very. It was very expensive, and I remember Dr. Kevin Chung over from the Army, who's like an expert with ECMO. He came on not my show, actually. The first medical device podcast that actually was not my show. It was one I started at Petro, but he came on. He was, they did a lot of ECMO during COVID. The problem with it is just like it costs a lot of money, and so a lot of hospitals made money because it's just. It's not like an evil thing. This is just the business model, which is like, hey, these people are gonna we gotta put them on ECMO. So there's just a massive amount of costs that came with COVID.
But I mean, when you look at the outcomes, 90% mortality. 90% mortality.
Yeah, so it wasn't like it worked. So going back to you now, what's different about NeVap? All right, so we understand that with the breathing tube, it goes into the lungs. You have this sort of cascade of really shitty events that happen, right? So what does NeVap do that's so different?
Well, we're not in it to make a buck here. We're not in it to basically build a piece of equipment that solves a problem in an expensive way.
Can I interrupt? You're a clinician. I'm gonna say, if I may just say this on your behalf. Mm-hmm. I totally get it. You're not in this to make a buck. But I think you should. And I think you should make a lot of money. And the reason why is that when I look at society and I see, I don't know, things that are really not that important and they're making a lot of money versus stuff like this that are going to save people's lives, like I'm actually very happy if you make more than just a buck on this. So I'm very pro medtech founders, clinicians making a lot of money to come up with things that save people's life. And again, no offense to my buddies over at the pharma world, there's some great innovations in pharma. But the thing that's interesting about devices that's different from pharma, from devices, it's an intervention. It's done. It's not like there's a massive lifetime value that you get out of the patient. It's just like we come up with interventions to save people's lives. So I'm very pro. I hope you make a lot of money off this. That's just me. Okay, that's just me. So please continue.
But what we want to do is we want to make devices that really matter and really make a big impact at the right point of view. And where we're going to make money is when people look at this and say that just makes so much sense that we just got to all do it.
Yeah, and so essentially you're not developing something that is like astronomically more expensive, right?
Right.
But essentially you're trying to become the new standard, right? Which is similar. I mean, when I was at Petro, I can appreciate what you're doing. I mean, for us, we had capital equipment, so it was a little bit different. But for us, we're trying to innovate around a century-old technology, which is the catheter, right? There's all kinds of similar to issue with you. There's all kinds of issues with infections and acute kidney injury that are associated with catheters that we just got used to and accepted. We shouldn't accept. Same thing with this. So the NeVap tubing, I've seen it, but can you describe it so that people have in their mind what exactly is it doing that's making it so different? By the way, on I'm going to plug your website here. It's .co, but on nevapp.co. So on the left hand side is other suction tubes. On the right hand side, it's NeVap. So essentially, with other suction tubes, you can see that the ooze or the saliva and everything starts dripping through. NeVap, it's catching it. It almost looks like you have a Foley catheter within a breathing tube. Actually, now that I think about it,
very, very similar. Yeah, we just have a little appendage at the end, right above the balloon, and it sits there and it just suction and catches all the fluid before it has a chance to fall into the.
So there's some suction. So this is essentially. Obviously, it's platform agnostic. So this just sucks up to any ventilator, and okay. So then there's really nothing extra. It's just a disposable, right?
Yes.
It's not like there's expensive capital equipment involved or anything.
Yep.
So
and I'm maybe I shouldn't tell you this because it's not published yet. But if I leave out the details, we have a little hospital in Illinois that's been using this tube for 6 months, And they've been tracking the benefits of this judiciously because during that time they didn't have anything else that was changing in their system. The NeVap tube reduced the average time a patient spent on a ventilator dramatically in across the board. And what's very interesting was even in coronary artery bypass patients, the number of them who ended up on a ventilator for longer than 6 hours post surgery was dramatically down. I will tell you, was reduced by 75%. And all it took was a different plastic tube and a little bit of open mindedness to use it. And this data is going to be published in the next 6 months. So, when it happens, we can talk about it a little bit more. But what we have here is something that got patients very sick, the sickest patients in a hospital, off the ventilator sooner without spending billions of dollars. And it's been done in tens of thousands of patients, but the study will include several hundred patients. And we didn't pay for it. Our customers looked at this, they tried it, they liked it, they figured out it works, and then they tracked what it did for them.
That's pretty impressive that you got that to happen because one of the problems, again, this is kind of like, this is just, it is the nature of the beast. But, if you introduce a new technology, implant, catheter, whatever to a hospital and you're like, hey, we're going to eliminate your infection rate. Infection control has a huge issue because they're like, well, if we do a study, it's going to show how bad we are.
Yes.
So was that like, how much of a struggle was that for you guys to get around?
That's the biggest struggle of all. Even if you have a device that clinically you can see the fluid coming out, you can't approach hospitals and say, I want to solve your infection problem because, again, in this country, ventilator-associated pneumonia is a dirty word. They don't talk about it. And to this day, even large trauma hospitals will claim, we have no ventilator-associated pneumonia, so we have no problem to solve. And statistically speaking, that is absolutely impossible.
Yeah.
Absolutely impossible.
Well, it's exciting to hear that you got this thing coming out and being published. When do you think is it going to be published roughly?
Probably early Q1 of next year.
Okay, great. Well, definitely when you get that publication, please post and tag me so I can share it on LinkedIn. But that's definitely really exciting and huge, and more importantly, like the impact on patients is so important because, again, what we don't often think about is you can go in for like a fairly normal procedure and end up in a world of hurt for a variety of reasons, even a healthy individual, just because like if you're just in there on the wrong day and you get a little bit of a nasty infection, right? Then you have all kinds of issues. And even if you recover, I mean, these are effects that are going to have a lasting effect on you for a long time.
Yeah. We in modern medicine, we think of infections as something that, we can just write a script, get a drug, and we can treat it. And I always like to remind people that for modern medicine, antibiotic resistance is our climate crisis. Antibiotics are the only drugs where, you use them longer and more extensively, and they get less effective every time.
Yeah, and not to mention, it's funny. I just had Barham Obade, who's a big thought leader he's a gastroenterologist out of Mayo Clinic, and we were just talking about like the gut microbiome and the importance of it because that's the other issue with these antibiotics and
Right.
especially antibiotics is that the impact they have on gut health, right? Which impacts we were talking about it today. And there are links to that and Parkinson's, to cancer, to all kinds of issues. So there's, I think, like. Not surprisingly so, the human body is really complex. And as we become more advanced in medicine with data and AI and everything, we're starting to realize like how, you might have something to solve one problem, but the solution also ends up giving birth to like 2 or 3 other issues that you're not aware of until later on down the line.
Absolutely. If I can give a little tidbit of advice here to your listeners, who might be interested in entrepreneurship, is to really think differently. When you look across the board, there are hundreds of different cardiac related therapeutic companies, biotech. They're all doing something in cardiac. And then when you look at, say, my field, like pulmonology and respiratory care, it's almost empty. You almost cannot find, half a dozen companies that are really doing something innovative. Either they're making a better battery or they're making a new kind of ventilator. But the truth is, if we're going to really move medicine, and if you're looking for fertile ground, you're looking for places where people haven't thought and haven't done things, and NeVap is one of those really interesting cases where people thought this was not an interesting field and not fertile kind of areas to innovate. And what I can tell you is, in the next couple of years, we're going to be introducing things to address one lung ventilation, left and right lung ventilation, ARDS, lobe specific therapeutics, to be able to give chemotherapy to a specific tumor in a specific part of the lungs. We look at the lungs as, I think many companies look at the heart. It exerts its benefits on the body through movement. And if it's anything that we have learned from the interventions of the heart, is that if you can harness that kind of philosophy, there are enormous opportunities to innovate.
No, 100%. I think, and I'm glad you mentioned that, just because, I think in entrepreneurship, I'll take myself, for example, the area that everybody was looking into SaaS, and I, came back to MedTech for a reason, because I was like, no, nobody's trying to do anything or innovative here. And I think it's the same thing, is that I think there's value in going to places where it's wide open and blue oceans, as they say. And then look, just in terms of the pulmonary area, look, Fred Moll went and started Auris, and they had a variety of places to go down, but they decided to go specifically the pulmonology application first, and that company got bought for $6 billion, and they were commercial for 6 months. And so I think there's value to that. Just in kind of wrapping up, and again, thanks for coming on the show and sharing this. What would you say are sort of the big goals and steps for you guys in 2024, which is right around the corner?
Yeah. We're a commercialized company. We actually sell our products into 6 different continents, over 25 different countries.
How do you do it here in the US? Do you have a direct sales force, or are you mainly working through distributors?
All of our sales are through distribution partners. Some of them are in small independent specialty distributors. Some as small as 2 states. We have one that covers Hawaii. We love it. And then we have some that are nationwide in the United States, and another one that covers most of Latin America. So we work with partners that know the field and know, how much it matters that they have something good in their hands to sell. And we've had a lot of success doing that.
Fantastic. Well, Benjamin, thank you so much for coming on the show. I'm going to remind our listeners, go check out their website, NeVap, NeVap.co. And then Benjamin is also on LinkedIn. You can look him up as Benjamin Wang. Benjamin, thank you so much for coming on. Thank you for listening. There's been another episode of the State of MedTech. I'm your host, Omar Khateeb, and we'll see you all next time. If you haven't already, subscribe to the show. Give us 5 stars.
Thank you for enjoying another epic episode of the State of MedTech. If you're feeling inspired and love this episode, do us a favor, hit that subscribe button and turn notifications on so you never miss an episode. And be sure to give us 5 stars and write a short review, because that helps more people discover this amazing community of ours. If you're a company who has a executive that you'd like to be on the show, or perhaps you want to sponsor one of the episodes, shoot us an email at hello@khateebandco.com. Take care, and we'll see you next time.